Good evening, folks. Welcome to webinar number 10. It's Dr. David Rawson, President and Founder of the Canadian Academy of Clinical Sleep Disorders Disciplines, long word, CACSDD for short. The topic is, if the snoring is gone, is there still sleep apnea? The need to titrate dental sleep appliances for credible and effective treatment of OSA. For those of you who do any amount of dental sleep medicine, you'll know that the patient will tell you, hey doc, my wife says it's all good, there's no more noise, so I'm finished, right? I don't need to come back. No, you need to come back. No, my wife says it's fine. So separating sleep apnea from the noisy part is an ongoing battle that we all can share. And I can't think of a better person to address that topic than Dr. Lettieri, who is a professor of medicine in the Uniformed Services University and the director of respiratory therapy for Johns Hopkins. He's board certified in internal medicine, pulmonary medicine, critical care, and sleep medicine. This man is overly trained and never gets home because he's studying like crazy. He also was medical director for sleep medicine at Walter Reed in the States. And as I say, he presented to us in uniform in 2017, and he's agreed to come back to be with us again tonight. So without any further ado, I will ask Dr. Lettieri to begin.
Yeah, thanks for having me. I appreciate the opportunity to talk to everybody. Hopefully this is beneficial for you guys. So as David said, the topic for tonight is really, what do we do with snoring, and should that be our primary end state when we look for oral appliance therapy and determining whether or not it's being effective. So I don't have any disclosures. So tonight we're going to be discussing the spectrum of sleep disorder breathing and the use of oral appliances in the treatment of sleep apnea. The purpose of tonight's talk is not to differentiate snoring from sleep apnea, but rather to appreciate where snoring falls along the spectrum of sleep disorder breathing, and to better understand both its roles, the role of snoring, and the limitation of using snoring in determining whether or not sleep apnea exists or is effectively treated. Sleep disorder breathing is really an umbrella term that incorporates several disorders of abnormal breathing during sleep. So that can include both centrally and peripherally mediated conditions. The vast majority of those that we see in clinical practice are caused by some degree of narrowing of the upper airways or the peripherally mediated, but narrowing of the upper airways that leads to some mechanical obstruction to normal laminar flow of air. Are you guys seeing the, I'm sorry, my computer is lagging, sorry. So, the obstructive or peripheral sleep disorder breathing is really a spectrum of pathologic narrowing of the upper airways during sleep that limits, disturbs, and even stops the normal flow of air. And that results in adverse consequences. So when we talk about sleep disorder breathing, really what obstructive sleep disorder breathing, it's narrowing of our upper airways, causing some form of limitation of airflow that also causes an adverse consequence. So upper airway obstruction during sleep, it's not all or none. It's not an all or none phenomenon, but rather it occurs from across a spectrum of severities. So to appreciate that, we really first have to understand what happens to the upper airways during sleep. Muscle tone maintains airway patency and keeps our upper airways open. During sleep, all of our muscles relax to include those that hold open the upper airways. So as we fall asleep, our airways begin to narrow. Everybody does this. Some people narrow more, or they have smaller caliber airways to begin with, and they're prone to airflow obstruction. So this effect is more pronounced when we sleep on our backs because of the effect of gravity. Other people, especially those who are overweight or have larger tongues or more redundant upper airway tissues, and some people have more collapsibility. So when we go to sleep, everybody's airway narrows. Some people narrow more. Some people have floppier upper airways. Some people have fat upper airways, small upper airways, small micro or retrognathia, whatever the case may be. There are some people from multiple different reasons that are more prone to collapsibility of their upper airways or narrowing and limitation of that airflow. That effect is even worse whenever we use alcohol or other CNS depressants, just because it causes more collapsibility of the upper airway. And that can contribute to greater limitations of airflow. That's why some people only snore when they're drinking, or they only snore on their back because of the gravitational effect, or they snored when they were overweight and they stop snoring when they lose weight. So snoring, again, it's just one sign or one symptom of a narrowed upper airway. So the degree of airflow obstruction falls along, just like we have that narrowing, the degree of airflow obstruction falls along that same spectrum of severity. As airways begin to narrow, airflow becomes more turbulent. That's snoring. Snoring is nothing more than the sound of turbulent airflow in the upper airways. And as the upper airways narrow more, the resultant decrement in airflow increases along that. Again, we're talking about a spectrum from snoring to upper airway resistance, then to mild, moderate, and then finally severe sleep apnea. Snoring is the most basic form of sleep disordered breathing. Primary snoring is defined as sleep disordered breathing that does not result in airflow obstruction or sleep fragmentation or daytime symptoms. Basically, it's snoring without any evidence of obstructive sleep apnea. That's primary snoring. Now, while primary snoring is a defined entity with very specific diagnostic criteria, the problem is that snoring by itself is poorly defined, and it's really unclear when and if primary snoring should be treated. So there's no unifying definition for snoring. Technically, any turbulent airflow in the upper airways is snoring. That could occur during both wake and sleep. But there's clearly tremendous variability with regards to volume and chronicity of this. Some people snore on occasion, some people snore just in certain stages of sleep or in certain body positions, some people snore continuously, some people just make small upper airway noises, and some people disturb sleep in their next door neighbors, right? So snoring that wakes our neighbors may be more annoying, but by itself is no more or less pathologic than a person with just some mild upper airway noise when they sleep. So as for treatment, snoring by definition doesn't impact an individual's sleep. If it did, it wouldn't be snoring, wouldn't be primary snoring. So by that logic, snoring itself doesn't require treatment. However, just because snoring doesn't disrupt the snorer's sleep, it doesn't mean it isn't problematic. Snoring can have a profound impact on the sleep and sleep quality of bed partners. And actually, it's one of the leading causes of divorce in the United States. When we updated the AASM clinical practice guideline for oral appliances, we explored all of the existing literature regarding the treatment of primary snoring. So this is, again, snoring without any evidence of sleep apnea. And what we found was there was a high level of evidence that treatment of primary snoring was beneficial. There was very little harm. And primarily, it should be treated with oral appliances for anyone who requests therapy. So the next condition along the spectrum of obstructive sleep disorder breathing is upper airway resistance syndrome. So as the airways narrow, the resistance of the upper airways increases. And basically, as the airways begin to close, it can lead to disruptions in sleep with brief awakenings in order to restore normal tone and airflow. Well, the same thing occurs in obstructive sleep apnea. As we fall asleep and our airways collapse and we stop breathing, our body senses, we don't, either through chemoreceptors, baroreceptors, drop in oxygen saturation, but that tremendous increase in upper airway resistance tells our body we're not breathing, and we have an awakening in order to wake up enough to restore normal muscle tone, increase airway patency, and start breathing again. Well, the same thing happens in upper airway resistance. The only difference between that and sleep apnea is you don't have the frank apneas and hypopneas. So basically what's happening is as the airways close, patients will sense this and wake up right away. So like sleep apnea, obstructive sleep apnea, it leads to frequent disruptions in sleep continuity, and that can lead to daytime somnolence and impairments in both physical and cognitive performance. However, it doesn't have the frank apneas and hypopneas, and many people will think that can hypothesize that upper airway resistance syndrome is just the mildest form of obstructive sleep apnea. And in fact, several studies have shown that people with obstructive sleep apnea most likely started with UARS, and those with UARS are more likely to progress on to obstructive sleep apnea. And really it comes down to it's a conditioned state. When you first start closing your upper airways, you're going to sense it right away. Imagine if I choke you, you're going to sense I'm choking you and you're going to fight me off. But if I choke you over and over and over again every single day for the next 10 years, at some point you just get used to it. And that's really probably what happens with sleep apnea. It starts with upper airway resistance. As your airways start narrowing and closing, you sense it, you wake up right away. Over time, you get more used to it. You reset your CO2 thresholds. You tolerate longer and longer hypopneas and then apneas. And that's why we see people will progress over time from UARS to mild, moderate, and severe sleep disorder breathing. Now, when it comes to UARS, should that be treated? Well, in theory, you shouldn't be studying people unless they have some symptom and you're trying to find a diagnosis. So if you find UARS, it should be in a symptomatic person. And just like mild sleep apnea, if they're symptomatic and they have UARS, they should be treated. And the evidence shows that treating it improves outcomes with very little harm. If they're asymptomatic, you don't need to treat it, but I'd argue, why did you do the study if they're asymptomatic? And how do we treat UARS? The same way we treat sleep apnea, usually starting with an oral appliance or positive airway pressure. So as the airways narrow more, we went from primary snoring to UARS, now we narrow more, and it narrows enough to lead to a true limitation in or even cessation in the flow of air, and those are apneas, or hypopneas and apneas respectively. And that's what defines obstructive sleep apnea, which is the result of repetitive apneas and or hypopneas that result in sleep fragmentation, oxygen desaturations, increased sympathetic tone, and those lead to adverse consequences in both health and quality of life. So while sleep apnea is the result of airflow limitations, and it's defined by those apneas and hypopneas, they are not what causes the pathophysiologic derailments and detrimental effects of sleep disorder breathing. So these adverse consequences are the result of really, if you break down into three different phenomena. One is the mechanics of that increased upper airway resistance. The second one is disruptions of normal sleep. And then the third is the consequences of repetitive arousal. So let me explain those and why I'm deviating away from our true topic is because I think you have to understand all of this. And when we circle back around, we'll, I think, better appreciate what it is that we're trying to accomplish with oral appliance therapy. Let's talk about those three different phenomena and why sleep disorder breathing is bad. So the mechanics of increased upper airway resistance. So I can break it down as simple as this. I breathe in, I breathe out. If I close my upper airways, if I have enough increased upper airway resistance, not only am I having ineffective gas exchange, right? I'm not having the normal flow of air. When we breathe, I raise my chest, I drop my diaphragm, I create a larger interthoracic space that causes a negative transpleural pressure gradient. I suck air in. Well, if I can't suck air in, I suck acid up. And that's why reflux disease, especially nocturnal reflux, is so common with sleep apnea. And you know, if you're for the dentists in the audience, you can see the erosion of people's teeth. You know, I'm sure there's things that you look at and you can say, hey, you're probably having reflux, and they may be completely asymptomatic or don't realize it because most of that occurs at night. And it's all because of that change in upper airways. Those other things that change in the upper airway, the mechanics of upper airway closure, leads to a lot of not only the acid reflux, but changes in our pressure gradient. That leads to a lot of upper airway edema. And so it's why sinusitis or chronic rhinitis, chronic sinus congestion is so common with people with sleep disorder breathing, and up to 60% of people with sleep apnea will have chronic sinusitis. The next phenomenon that I mentioned was disruption of normal sleep. Well, right, sleep is not yes or no, it's not on or off. It's a very complex constellation of things that really sleep is not just the antithesis of wake. To be awake, you have to promote wake and to block sleep. To be asleep, you have to promote sleep and block wake. And so we have to align sleep with our normal circadian rhythms and all these different processes that turn on sleep and turn off wake. And then sleep by itself is very complex. and we sleep in different stages. There's N1, N2, N3, REM sleep, and each of those different stages have different processes that occur that helps us restore our body and mind, and regenerate, grow. We grow muscles, we have neuroregeneration, we lay down new neural pathways. And so when we have fragmentation of normal sleep, we have wake up, wake up, wake up. Not only does those constant awakenings lead to overall just chronic sleep deprivation, doesn't matter how many hours you're in bed, if you're not getting good sleep, you're going to be sleep deprived, but also disrupts normal sleep architecture. So all those normal restorative properties that occur in those different stages of sleep get lost. And the third consequence of sleep disorder breathing is just repetitive arousals. Again, it's not about the apneas and the hypopneas. You can hold your breath for 10 to 20 seconds. You're not going to hurt yourself. In fact, you're not even going to drop your oxygen saturations. So what is it about sleep apnea that's so detrimental to have all these repetitive hypopneas and apneas? Well, again, those are just the objective marker, right? It's the marker that we use to determine if sleep apnea is present and how severe it is, but the apneas and hypopneas aren't what's causing the problem. It's those, not only the increased upper airway resistance, the mechanics of it I mentioned, the disruption of normal sleep, but then the consequences of repetitive arousal. Again, coming back to this concept, if I choke you, you're going to surge your catecholamines. And if I do it over and over and over again, your catecholamine tone is increased. So they have increased sympathetic activation that leads to all the cardiopulmonary derangements, and elevated stress hormones that go on to ultimately lead to all the metabolic and cardiovascular consequences of sleep disorder breathing that we deal with so very frequently. So let's now turn around to snoring. Snoring is clearly common in patients with sleep disorder breathing. However, it has limited value in predicting or diagnosing sleep apnea. So why is that? Well, as I mentioned, snoring itself is poorly defined and it's often under-recognized. And we know this from those of us who do sleep clinic. We ask people if they snore and they say no, and then they come and do a sleep study and they're snoring throughout the whole thing. Well, how do they know? Unless they have a bed partner who's also, who is being awakened by snoring, they may not even realize it, or they may only think of snoring as something that's, waking the dead and not just that mild turbulent airflow in the upper airways. So not because we don't have a good definition for snoring and because it widely varies what people think snoring is or isn't, and because it occurs at night, people may be unaware. So clearly snoring not only poorly defined, but it's very under-recognized. And while the majority of patients with sleep apnea have snoring, or I should say, while the majority of patients with sleep apnea snore, not everyone who snores has sleep apnea. And not everyone with sleep apnea snores. So I have the numbers here, and there's always a range depending on the study, but at least in the United States, 40% of men and 20% of women snore. Other studies have shown it's 65%, up to 65% of men and a third of women snore. So snoring is extremely common. Well, we also know that most people with sleep apnea snore, but not everybody. 15 to 30% of sleep apneics have never snore. And then not everyone, right. And so not everybody who snores has sleep apnea, not everybody sleep apnea snores. And some people have snoring that don't have sleep apnea. So it's really hard to use this as a diagnostic tool to either say you snore, must be sleep apnea, or even predict you may have sleep apnea. There has to be much more. The importance of snoring well overplayed, not only in determining who has sleep apnea, but then determining if sleep apnea is properly treated, which we'll get to that in some subsequent slides. So the other thing is the presence and magnitude of snoring don't correlate to the AHI or to the degree of symptoms, meaning that a person with very mild snoring compared to a person with heroic loud snoring, can't say one has a more severe sleep apnea than the other, and you can't say that one correlates with consequences of sleep apnea more than the other. So just using narrow snoring by itself can both overdiagnose OSA in some individuals and completely miss the diagnosis in others. So we'll come back to the problems with snoring momentarily, but right now let's change our focus a bit and discuss what we're trying to accomplish when we treat sleep apnea. So regardless of our choice of therapy, whether it's PAP or oral appliance or positional therapy or surgery, it doesn't matter. What are we really trying to do? Well, the primary goal And really the only goal of OSA therapy is to resolve upper airway collapse and restore normal patency of the upper airways. If you do that, there is no more sleep apnea. If there's no more sleep apnea, then all the detrimental effects that go along with sleep disorder breathing resolve. So the basic markers for this, and what we use to define successful therapy are ablating obstructive events and normalizing the AHI, resolving snoring, resolving daytime sleepiness, and improving daytime function. So why those? Well, because we like numbers, right? We're scientists. We like to count things. We like objective markers. The AHI is something I can count. As the number goes up, things must be worse. And as the number comes down, things must be better. Well, snoring, we just chose that because, well, snoring is pretty common with OSA. And if they're still snoring, they probably still have OSA. So unless we fix snoring, we probably haven't fixed the sleep disorder breathing. We're going to have some slides on that. That's not necessarily true. We want to fix daytime sleepiness. Well, because that's an easy one, right? People don't come to my clinic and they complain, hey, doc, I think my AHI is high today, or I'm worried about my long-term risk of cardiovascular disease, or maybe my sympathetic tone is elevated. No, they come in and say, I feel like crap, or I'm super tired. You got to do something to help me. And so that's why it's such an important end state. And really, when we first started to find, people before me first started to look at OSA, that's really all they had AHI and daytime sleepiness. And it wasn't over time that we started realizing all the other detrimental effects that go along with sleep apnea and all those other consequences that have been associated with sleep disorder breathing. So those measurable goals of successful therapy are there, and they're undisputable. We have to remember that there are several other very important goals of therapy that even if we don't measure for them, we still have to look for them. We have to take care of them clinically. There are no less important than those things I mentioned, the AHI, sleep, the daytime sleepiness, and daytime function. So specifically, we want to resolve sleep fragmentation. I mentioned the three consequences of sleep disorder breathing. One of those is fragmented sleep. And if we need to restore normal sleep continuity and then restore normal sleep architecture because of all those restorative properties that go along with sleep. We also want to normalize that sympathetic tone and restore normal cardiopulmonary physiology because that leads to all the the long-term consequences of sleep apnea. And we want to prevent further end organ dysfunction that was caused by the underlying sleep disorder breathing to begin with. So unfortunately, those aren't easy to measure. And those aren't something that's going to be fixed overnight. Whereas with PAP and oral appliances, they're very good at fixing objective markers of sleep apnea. They're not as good at fixing these other endpoints of sleep disorder breathing, but that's largely because of either insufficient therapy or, unfortunately, for most patients, inadequate adherence to therapy. So those are the goals of therapy, right? But when it comes to how we define successful oral appliance therapy, there's tremendous variability in what we consider to be successful. So different trials have really used different definitions of success. And these were some that I just pulled out of a lot of the articles that I've reviewed over time, or that I included in some of my, in our CPG and in some of the book chapters I've written on oral appliances. I've read more than my share of the oral appliance literature. And you can see here, there's a tremendous variability in what people say in their trials as what they define successful oral appliance therapy as. Well, you can see that this has got to be problematic. And one of the problems is that these don't necessarily capture what the true goals of therapy are that I just mentioned. They focus purely on the AHI, most of them. Some of them look at daytime function, daytime sleepiness, but most of them really look at the AHI. And if you look at some of these, well, an AHI under 5, no one's going to dispute that that's, should be your goal of all forms of sleep apnea. If you have sleep apnea, treat it to where you no longer have sleep apnea. An AHI under 10, maybe, but an AHI under 10 is very different than an AHI under 10 with resolution of sleepiness, which is also different than an AHI under 10 with improvement in sleepiness. Some of those that have 50% reduction in baseline AHI, well, that's fantastic. If you come in with the baseline AHI of 6 and you go to 3, it's a 50% improvement. But one could argue, yeah, but you're only reducing it by 3. Is that really clinically important? The flip side, if someone comes in with an AHI of 80 and you narrow it, get it all the way down to 40, who cares? They still have severe sleep apnea. no one's going to think that's successful therapy if you leave somebody with severe sleep apnea. So there's got to be more to it than just a 50% reduction based on AHI. A 10%, reducing the AHI to less than 10 and improve daytime symptoms. Well, if they go from horrible to bad, that's improved. But no one would believe that that's a successful treatment, right? So we have to have very strict definitions. We have to understand what it is that we're talking about. And the other thing, how can anybody truly understand or appreciate if oral appliances are working if we aren't using definitions that are consistent with what our clinicians are trying to accomplish? And that was the slide I just showed. If our treatment isn't accomplishing those end states or those end treatment goals that we want, then it's not an effective therapy. The other thing is, how can anybody outside of the oral appliance or dental sleep medicine community really appreciate the value of oral appliances if our literature is all over the map and people are using definitions that clinicians don't believe are successful, right? Those could have been very successful treatments, but if we don't define it properly and don't report it properly, then no one's going to believe that they actually work. So these different definitions can have a huge impact on how we determine the treatment effect and whether or not we consider that person to be successfully treated. And this variability increases when you have higher AHIs, right? That makes sense. Small AHIs are going to have small deviations, and people with high AHIs, well, changing the definitions are going to have a big difference in whether or not that they were quote unquote successful or not. So even the difference between using the AHI of less than 5 versus an AHI less than 10 can largely vary or largely alter the rate of successful therapy in one individual study versus another. So just for an example, I'm showing data from 2 fairly large oral appliance studies. So I did one with Aaron Hawley on the left and then Phillips on the right. And you can see that both had, using the 2 different definitions, there was a very large difference in the rate of successful treatment. So in both studies, patients were, now, unlike a lot of oral appliance studies, I will say in both of these studies, patients were all titrated to a maximum effect of their oral appliance. So they didn't just get oral appliance and then restudied, or they weren't just advanced to some arbitrary number. Both studies, they were titrated to maximize the effect of oral appliance. And in both studies, there was about a 25% difference in success rates just by changing the definition from 5 to 10. Well, you imagine if you change the definition of success from 10 to 20, it's going to go up by 50-fold. In fact, it went up 55% more if you change the definition to 20. So it's hard to write. You can say you have a successful therapy if you just set a very low threshold for what you think is successful. It's very hard to show successful therapy if you have a very stringent and tight definition, but that's what's applied for in PAP. And so really, if you want to compare apples to apples, we need to strive for an AHI of less than 5, even with our oral appliances. And it can be done, I promise you. All right, so that being said, what should the ideal goals of oral appliances be? Well, quite frankly, like I said, they have to be the exact same goals as PAP therapy. And that's an AHI under 5, or really an AHI that's as close to 0 as possible. Because I will tell you, people with an AHI of 4 on therapy, many of those still have room for improvement and they'll still be somewhat symptomatic. Now, so the idea is getting the person as low of an AHI as possible. Now, I will absolutely agree that there are some people, if you get their AHI to 10 or even 12, because they were really bad before, and that's the best you're going to do, especially the morbidly obese people, that's clearly got to be better, right? It's got to be better than an AHI of 80, especially if you're improving neurocognitive function and cardiovascular health. But for most people, we want to try and get that AHI we want to ablate all their events. We want to get that AHI as close to 0 as possible, with the understanding that sometimes the enemy of good is better. I get that. And sometimes you can, overdo it and hurt people by just, by not being happy with an AHI 4, right? So sometimes we push them too far. But overall, try and get them as close to 0 as possible. Because what you're really trying to do is ablate obstructive events in supine REM sleep. So what do I mean by that? So in REM sleep, our stage of sleep that we get crazy dreams in, we lose all muscle tone, right? So that we don't act out our dreams. And there's a whole different, very cool sleep disorder where people act out their dreams, dream and acting behavior, REM behavior disorder. But for most people, we're paralyzed, completely paralyzed in REM sleep. So if you have no muscle tone, and remember going back to what we said earlier, that's what's maintaining upper airway patency. So if no muscle tone, clearly we're very vulnerable to collapse. And then again, on your back, because of the effects of gravity, everybody has this effect of gravity. So if I can fix your sleep in the supine position in REM sleep, if I can ablate your vents then I know you're well treated, right? Because that's the most vulnerable state you can be in, at least when it comes to upper airway collapsibility. We obviously want to restore snoring, because if they're still snoring, then they're probably still have increased upper airway resistance, right? If they're snoring, that means there's got to be some degree of airflow limitation. They may not be having apneas, hypopneas, but they still have, airflow limitations, and that's what's leading to turbulent airflow, and that's what's causing snoring. So if we haven't fixed the snoring, there's still got to be something going on there. We want to prevent sleep fragmentation and arousals, because as I mentioned, that's what disrupts normal sleep architecture, and that's what leads to all the lack of restorative, we lose the restorative properties of sleep. We need to normalize oxygenation, obviously, because that leads to contributes to a lot of the cardiovascular derangements that go on there. So simply resolving snoring is just insufficient as a sole marker to find successful therapy, because patients can still be having obstructive events and sleep fragmentation may still be occurring, and even in the absence of snoring, right? So while snoring is if we think about as our airways start narrowing, well, the first thing that's going to happen as they narrow is snoring. So the first in, the first out. If we start opening up the airway, the first thing we're going to fix is snoring, but we can still have a lot of upper airway collapsibility, even if people are not snoring anymore. So let's take a look at the AADSM's definition for effective oral appliance therapy. So it mentions improvements in the AHI, improvements in daytime sleepiness, improved cognitive function, and improved cardiovascular health and quality of life. Now, we can argue that their definition is far too vague, and it doesn't, and its ability to use specific criteria was pretty limited, right? So they say improved cardiovascular health, improved AHI, improved daytime sleepiness. They didn't say by how much, right? They didn't give us a threshold of what the AHI should be, right? They just said improved. So why didn't they give us very specific guidelines? Well, largely because of the oral appliance trials that were out there. Because as I mentioned, those widely variable definitions for what was successful therapy really did limit the AADSM's ability. And just like when we did our clinical practice guideline, those really did limit the ability to make thresholds of what's considered successful therapy or not. But one thing is clear when we look at the AADSM definition, it doesn't mention snoring at all. It doesn't mention resolution of snoring as a definitive measurable endpoint in determining treatment efficacy. Why? Because it shouldn't be used that way. Unfortunately, it's used that far too often. I see this in clinic, all the time. I have discussions with people about this all the time. And this is why we're talking about it tonight, because far too many people just focus on snoring as whether or not they have successful therapy. And I'm hoping by the end of the night, you realize there's a lot more to effective treatment of sleep apnea than just fixing the snoring. Now, I can't beat up on, the AADSM, too much, because again, like I said, we had similar limitations when we wrote the ASM oral appliance guidelines. But what we did recommend objectively measuring the AHI and ensuring that events were ablated. Why? Because again, we can't just rely on the patient's subjective reports. The only way to know if a person's AHI is improved is to do repeat studies, repeat sleep testing on therapy. And again, not to solely rely on a patient's subjective reports of improved sleep quality or even resolution of snoring, because, and multiple studies have shown this, that sleep apnea can persist despite a person's subjective improvements in sleep or improvements of daytime sleepiness or improvements of snoring. Again, if you go from horrible to bad, people are going to feel better. So, right, I can't just rely on somebody say, well, I feel better, I sleep better. Again, these people have, fragmented sleep and daytime sleepiness and snoring. So they may be happy with better, but that doesn't necessarily mean good. So if we come full circle back to our original discussion, we can apply the knowledge about that progressive collapse in the upper airways across the spectrum of sleep disorder breathing and how we determine the treatment efficacy of oral appliance. Remember, it's not just about the apnea, hypopneas, right? So it's not about the AHI by itself. It's not just about resolution of snoring, but it's all about restoring upper airway patency. So we can have persistent events with or without snoring, right? You can have silent OSA, silent UARS. That's been well shown in the literature. And we can clearly have persistent events that patients don't recognize. People never know that their AHI is 50. I love bringing patients in to look at their studies, and I say, you woke up 387 times last night, and they're just shocked. They may think that they may recall waking up 2 or 3 times a night, right? We have retrograde amnesia in sleep, or some of these arousals are fairly brief, but even a person who wakes up 300 times a night can have mild sleep apnea. And still wake up 300 times a night, right? So that's not uncommon at all. And so, but clearly nobody realizes that they have that much sleep fragmentation. So, just relying on a patient's subjective assessment of their sleep quality is completely unhelpful, to be honest with you. So really to that end, and the fact is patients have events that they don't recognize. And to that end, we can't solely rely on a patient's report or even, free and improvement, even resolution of things like sleep fragmentation or snoring to determine whether or not an oral appliance was successful. And we have to remember that, what makes it even harder is those events can be missed on home sleep apnea testing very easily. And even on in-lab PSGs can miss some of those. But that's really why we have to have very strict definitions of what we consider to be successful therapy. And we have to use both measurable endpoints and subjective improvement in concert with each other, right? So I don't care if your AHI is, under 5, if you still have persistently fragmented sleep and daytime sleepiness, you're not well treated. And I don't care if you have improved daytime sleepiness and improved nocturnal sleep quality, if you still have frequent apneas and hypopneas, you're not well treated. We have to look at both of these. We have to look at them together, and we have to look at a host of things. And we have to go back to that slide I showed you. What are we really trying to accomplish when it comes to treating sleep apnea? And what are those end states, the end goals of therapy that we want to achieve in everybody? So here's the protocol that I developed at Walter Reed, or the Walter Reed National Military Medical Center. Now, I'm not saying that this is the best by any means at all. I'm just showing you what I do. But I will say we've been using oral appliances for the past 20 years, and we have treated literally several thousand patients with oral appliances in that time. And we have pretty high success rates. So we use, in everybody gets a titratable device no matter what, and we use an AHI of under 5 with subjective improvements in symptoms as our treatment goal. So using an AHI under 5 as that objective treatment goal, we get a successful treatment rates in 92% of patients with mild sleep apnea, about 65% in moderate, and nearly half the people with severe disease, which I think is fantastic. So what do we do? Again, everybody gets seen in a sleep clinic by a sleep provider and also by our sleep dentist. Everybody will get a titratable device that's custom fitted for them. So it's a customized individual titratable device. Everybody starts in a neutral position, meaning no mandibular advancement, just for them to get used to a few nights with sleeping with the device in their mouth. Not everybody is good with that. And then we incrementally advance them by, depending on the device we use, but let's just say a 0.5 millimeter each night, or we'll do a 0.5 millimeter, one incremental advancement, depending again on the device. And they do that for 3 days, and then they go, and so they only advance every 2 to 3 days, and they do it very small advancements. And they'll do a very in-depth home diary where they look at snoring, their subjective assessment of their sleep quality, whether or not they were dreaming. For men, we say, did they wake up with erections, because that's a sign of getting into REM sleep. How do they feel when they woke up? And then how do they feel during the day? Were they improving? And so when patients think that they have hit that sweet spot, when they subjectively have had successful therapy, then we'll do a home sleep apnea test just to make sure. And if they still have a lot of a high AHI, a lot of events or desaturations, then we keep advancing, slowly advance as tolerated. So we don't use an arbitrary 70% or 80% of maximum mandibular advancement. Sometimes you can titrate people too fast and they'll start having some symptoms. But I tell people, just like if I tell you to bend down and touch your toes and you haven't been stretching, you're not going to be able to do it. And if you go slower, most people can titrate a little bit more. I do believe you can over titrate people with oral appliances. We got to be careful of that. But we do confirm with home sleep testing. And then if they've had successful therapy subjectively, and their home sleep apnea test shows that their events are largely ablated or at our treatment goals, then we will decide with the patient whether or not they need any further titration, or do they need a confirmatory in-lab study. I would say over time, the in-lab study used to be everybody got an in-lab study. And then it was, largely replaced or changed by home sleep apnea testing. And then really it comes down to how severe their disease was. For mild disease, we typically don't do repeat in-lab studies. For all moderate and severe, they do. And then depending on what their profession is, right? So if they're a professional driver, certain jobs in the military, they cannot have persistent sleep apnea, pilots, things like that. They all get an in-lab study. But regardless, we individualize therapy. But when we look at what we define treatment success, it's again both subjective and objective measures. It's very tight definition, AHI under 5. But we have pretty good success rates with that. And notice how in their snoring only brought up one time, and that's they do have to have resolution of snoring, but clearly that's not the only thing we look for. So that was a lot, and I'd love to see if you have any questions. If I'm really going to summarize this for you, there is a huge spectrum of what we consider sleep disorder breathing. Snoring is the most basic of that, all the way to severe sleep apnea, but it all is the same pathophysiology, right? It's all the same narrowing of the upper airways, leading to some degree of limitation of airflow, from just turbulence to frank apneas. And along that continuum of airflow limitations is the same continuum of disease severity and adverse consequences. And treating it, whether you're treating with an oral appliance, surgery, PAP, positional therapy, the treatment goals have to be the same in everybody. And that's ablating events and improving their sleep quality, improving their daytime function. And we have to look at those, right? Those are the things we have to achieve. Don't just pick one of them. Don't just pick an AHI. Don't just pick sleepiness. Don't just pick snoring. And if for all of those, I will tell you the most problematic is snoring. If you're going to use that, I always tell people you're better off to ignore snoring when you're trying to determine who has sleep apnea or not, or to try to determine if your treatment is effective or not. Snoring just gets in the way, right? It throws people off. It gives people a false sense of security. If you fix the snoring, you must be fixing the sleep apnea. That is not at all true. I hope this was helpful for you guys. I'd love to entertain any questions you may have.